Hello, everyone. I'm Todd Didier, Communications Director here at the Primary Care Collaborative, a national organization that convenes stakeholders from across the healthcare landscape that are committed to improving the nation's health by strengthening primary care. I'm thrilled to welcome you to today's discussion on how primary care can navigate mistrust in medicine. We're grateful to our partners at the ABIM Foundation who are co-hosting this essential conversation with us. The ABIM Foundation has done a phenomenal job exploring distrust in healthcare more broadly, and we encourage you to take a look at their other materials on the topic. We've dropped links into the chat for some of those materials right now. Now, just a few housekeeping items before we get started. This session, like all PCC webinars, is being recorded. The recording will be posted on our website, thepcc.org, within 48 hours. You can find all of PCC's previous webinars on our website as well. As with most PCC webinars, we will be doing audience Q&A following the panel discussion. Questions can be submitted using the Q&A tool, which is usually found at the bottom of the screen. Feel free to send questions throughout the entire conversation. Just so you know, chat has been disabled for viewers, but our team will be providing links to relevant resources throughout the webinar, so please keep an eye on the chat box. Finally, the PCC is committed to delivering high-quality webinars exploring important topics to the primary care community. We'd appreciate if you took a minute or two after the survey to fill out the post-webinar survey so that we can ensure we are meeting that standard. Now, I'd like to introduce today's moderator. Dr. Catherine Gergen-Barnett is the Vice Chair of Primary Care Innovation and Transformation in the Department of Family Medicine, an Associate Professor at the Boston University Chobanian and Avedisian School of Medicine. She is also a Health Innovators Fellow at the Aspen Institute and an advisor for Massachusetts Health Policy Commission. She has researched and written extensively on a variety of topics, but is heavily focused on healing medical distrust. I also have the pleasure of working with her frequently as PCC's inaugural Communication Fellow. So just a few qualifications there, Catherine. Thank you so much for joining us this afternoon.
Thank you so much, Todd. I'm really excited about this conversation. So I just wanted to set a little bit of the landscape for why we're talking about this and, why we're bringing everybody together today. So I think as most people here understand that trust is really the invisible or sometimes visible infrastructure of medicine. Without it, we know that even the most evidence-based treatments fail to reach patients, preventive care goes unheeded, and health disparities widen. Yet across the United States, trust in medicine and in healthcare institutions more broadly is at a historic low. Communities that have faced the most profound health inequities are often the least trusting of the very systems designed to serve them, and for deeply legitimate, historically rooted, and present-day reasons. The erosion of trust is not a communication problem alone. It's a cumulative legacy of medical experimentation without consent, structural racism embedded in clinical practice, paternalistic care models, and decades of feeling unseen and unheard. At the same time, the forces eroding trust today are multiplying. We know that health misinformation spread faster than ever. The corporatization of medicine has strained the clinician-patient relationship, and the primary care workforce itself is under existential pressure. Primary care sits at the center of this challenge and also offers the solution. The primary care clinician is often the first and most continuous point of contact a patient has within the healthcare system. And when that relationship is strong, it can serve as an anchor of trust, even when patients mistrust the medical system writ large. When trust is fractured or when patients lack access to it altogether, the consequences ripple across every dimension of health. In fact, trust plays such a role in patients' health and health outcomes that I have argued, as well as others, that it is a true social determinant of health, just one we do not speak enough about. This panel brings together national leaders who are also amazing humans, who are working in clinics, communities, policy forums, and research to rebuild and sustain that trust. Together, they will explore what trust in primary care practice looks like, what gets in its way, and what it will take to make a more trustworthy, equitable primary care a reality for all Americans. And with that, I would like to introduce our panelists. Let me start with Dr. Lisa Fitzpatrick. Dr. Lisa Fitzpatrick is a hero of mine. She's a board certified infectious disease physician, a medical epidemiologist. She served as a foreign diplomat in the Caribbean. She's an academic researcher, a former chief officer for DC Medicaid program. She's also a member of Institute of Medicine, National Academy of Sciences Roundtable on Health Literacy, and an Aspen Institute Health Innovator Fellow. She's also the founder and CEO of Grapevine Health, a digital media health company she established to build trust and improve patient engagement among Medicaid patients through delivering culturally appropriate and relatable health information. Thank you for being here. Barbara Rapson is the president and CEO of Massachusetts Health Quality Partners, who just celebrated her 28th year of being at the helm. And under her leadership, MHQP has become a national leader in the measurement and public reporting of healthcare information, with a particular focus on measuring and improving patients' experience of care. In the last few years, Ms. Rapson has focused the organization's work around three main areas of impact: improving patient experiences, advancing health equity, and strengthening primary care. And finally, Dr. Asher Tulsky is a board-certified internist who serves as Associate Professor Emeritus of Medicine at Boston University Chobani and Avedissian School of Medicine. He also serves as a member of the American Board of Internal Medicine Foundation's Board of Trustees. So thank you so much for joining us today. So I'm going to ask each of our panelists different questions. And I really, as we are having each of you listening, the audience, I'm going to invite you to add reactions, conversations, questions into the chat. We will have time for Q&A and really excited for this conversation. So first, I'm going to start, and by the way, I'm going to use everybody's first name because they're all amazing humans, but we're talking about trust and it's all about relationships. So we're just using first names. So I'm going to start with you, Lisa, and just part of this setting the table here. So I know you've said that trust and trauma are not just buzzwords, that they are key factors that shape people's ability to understand and act on health information. Can you elaborate on that idea and also discuss what, in your experiences, it takes for a physician to become a trusted messenger?
Thank you, Catherine. And I appreciate being invited to this conversation. As you mentioned, I've been studying and talking to people about this for quite a few years now. So I really appreciate being part of the conversation. The reason I say trust and trauma really essentially contribute to people's willingness to engage in healthcare, but also determines whether or not they trust the healthcare system is because I've actually lived it. A few years ago, I moved into an underserved community here in DC because after all of those fancy jobs you just told everyone about, I thought we must be missing something. What is the disconnect between the services we're trying to provide and the communities we're trying to serve? And so living there for 3.5 years, I got a front row seat to understand what people are grappling with. And the trauma is real. We don't talk enough about it in healthcare. But it's not, when we talk about trauma, we often think about gunfire and interpersonal violence in the home. But I'm talking about a more subtle trauma, the trauma of living in scarcity and poverty, having to fight for everything. When you're poor, everything takes longer. So, and time is a currency we all value, but you have a lot less of that If you're living in an underserved community and you don't have the financial resources, a lot of us do. And so all of these things work together to determine whether or not people will prioritize walking into our clinics. We go on and on about the no-show rates, but we don't think about, well, why didn't Miss Jones or Mr. Smith show up? And maybe there are some other things we need to be thinking about. So I really want this idea that trauma and trust drive people's healthcare decisions to be central to a lot of the conversations we're having, even about value-based care, because I don't hear enough of those conversations rooted in the realities of what people are dealing with, because we're looking at it from our lenses and not necessarily through the lens of people we're serving.
Wow. There's so much about what you just said that really resonates in this idea of, trauma and trust driving people's healthcare decisions. And I want to kind of circle back to that. But I want to turn to you, Asher, and really think about your work. So we're here with the American Board of Internal Medicine. We know that ABIM has been doing lots of work on trust. We're grateful for their partnership. But I want you to really, I know you've been very much centering on how clinicians can better serve patients from structurally marginalized communities as well, but specifically around communication skills and thinking about communication skills as a core professional competency. So, building on, what Lisa said and your own experiences, what do you think primary care training gets right? And what does it get wrong in terms of preparing clinicians to navigate medical mistrust when they encounter it?
Well, again, I want to thank PCC for having me here. I'm really excited to be with this wonderful group. I would start by saying, having been a lifelong clinician educator and primary care doctor, recognizing that we do a great job of training our young physicians, internists that I work with, to really have expertise about the topics, to have a really strong knowledge base, to be able to bring in the most recent evidence. I think where we really fall short has been really how do we communicate that in a way to patients that recognizes where they're coming from, what their concerns are. Very often, what I hear from residents is, well, they just heard this from some friends or from the internet, and I just tried to nip that in the bud. And that's not really the approach that needs to be taken. I think you really have to start from a place of really curiosity and understanding what is it that concerns you most. Where'd you hear this? What appeals to you about it? What are the things you worry about? What are the things that I've told you that I've explained to you that you have concerns or more questions about? And unfortunately, despite the best efforts, time is always one of the biggest struggles, both in the visit and in the curriculum. I was fortunate to be able to develop a communication curriculum in the last program that I was in, that I worked for at BMC. And we had simulated patients, and that was great, but that wasn't enough time. And it was like one small part of their entire curriculum. So I think what we get right is we give them great knowledge, foundation. We don't do as good a job in being able to help them deliver that knowledge in a way that is allows people to really feel heard and to be express their own concerns and their own ambivalence.
Yeah, thank you so much. And part of what I also heard you saying ties back to what Lisa said in terms of why, especially when somebody is time strapped, and wouldn't necessarily prioritize coming in for a visit, why should it matter? Right. And part of what you're saying is you could have all the tools in the world waiting by your side medically, but if somebody doesn't prioritize showing up because you're not able to connect to them, then what's the point? Right. So it's bridging that gap. And then another piece that you said that I really wanted to put a pin on is this idea of curiosity, right? Because I would argue that that is a muscle that needs to be developed throughout not just medical training, but throughout an entire practice, right? Like the life of a clinician, I think we lose some of that curiosity muscle. And, part of the work I'm doing on trust is bringing together community members and clinicians and specifically building modules around curiosity, and how to do that, because that to me drives the human relationship, and with that is building blocks of trust. So thank you, Asher, and thank you for all you're doing for our learners. And Barbara, I'm very honored to work with MHQP and be, kind of under your tutelage, and learning a lot in terms of being a Massachusetts resident and the work that you guys are doing. But you all under your leadership, as we know, MHQP has really become a national leader, as I said, measuring and publicly reporting on patients' experiences, specifically focusing on the experiences of patients advancing health equity, strengthening primary care. But really importantly for this conversation, you all have been pioneers in thinking about measuring trust, putting it on the dashboard. So can you share with us, how do you actually measure trust? And what does this data tell us about where primary care is succeeding or falling short?
Thanks, Catherine. It's always a pleasure to work with you, and I'm honored to be on this panel with Lisa and Asher as well. So MHQP, given our mission is to improve the quality and equity of patient experiences of care, we have been surveying patients about their experiences with primary care for 2 decades. We do this statewide and we share results. And the domains that we've been focused on, we use a CAPS-like tool. So it's about communication and access and coordination. We have questions about knowledge of the patient. But MHQP, some of the other work we do outside of our survey, we've focused a lot on engaging patients. We've focused on assessing and managing pain. We've looking at how do we help patients get the right care at the right care at the right time, right place. And what we keep bumping into is this concept of trust. And the trust has a big influence on sort of everywhere we looked. It's like, okay, there's this trust thing that's crucial to being successful in all these other areas. And so we started looking at different trust scales that we could incorporate into our patient experience survey. And so in 2023, we decided that we would include the Wake Forest scale. And this has just a few questions that ask about making sure your provider cares more about you than they are about what's convenient for them. It asks whether your clinician is extremely thorough and careful, whether the decisions about your medical treatments are really best for you. And is your clinician honest in telling you about all the different treatment options? And then, an overall trust question. So we incorporated these questions into our survey. And when we got the results, we saw that, trust scales were reasonably high for the overall population. But then, of course, when we stratified the results by race and ethnicity, what we found was there's patients report significantly worse scores for Black, Latino, and Asian patients. And so we said, okay, we've got, what can we do about this? And so what we ended up doing was taking a deep dive. We got a PCORI grant and invited you, Catherine. We invited ABFM. We invited the Boston Public Health Commission, and we interviewed Black patients about trust with primary care. We interviewed primary care clinicians, and then we came together and thank you, Todd and Maximilian. They put there's a link in the chat about the work we did about how to reduce mistrust with Black patients for primary care. And so this has been a journey, and it's so what we're learning is it's a really important issue, particularly for certain populations. And once you start asking about this, you start learning that it's really an important, while there's certain populations have particular concerns, if you can improve that for certain populations, you'll improve the trust for all populations.
I'd love to add some perspectives on this idea of measuring trust. And I think once I say them, they might seem obvious to people, but we have not created a framework to capture this quantitative information. I believe non-adherence, No-show rates in the clinics are all measures of trust.
Yep.
Willingness to share information. People compartmentalize when they come and see us based on how much they trust us. They will, there are different vaults of information people present in clinics and clinical settings. And they decide based on how they feel about you whether or not they want to share from the deepest vault. And that's a measure. But I think we need to think about that. As the mantra goes, we measure what matters. And I think someone said earlier, we talk about this topic ad nauseum, but our actions aren't following to make sure we believe it matters, particularly as a cost driver, as a driver of health outcomes, engagement in care. So if we put our heads together, we have enough think tanks, like, well, let's make this a topic and figure out what are the quantitative measures and hold each other accountable for reaching those benchmarks. Because if medication non-adherence has such a high priority in healthcare, I mean, it's a triple weighted NCQA measure, which is a topic for another time because I have thoughts about that. But if it's such a high priority, why aren't we understanding it holistically? Because in my experience, a lot of the reasons people don't take their medication, in addition to not being able to afford it, is not trusting what we say, and they believe they don't need it. Why is that? Where's the information disconnect? So I think these things are all tangentially and integrally related to trust.
Yeah, Lisa, it's funny. I was actually gonna kind of call on you after Barbara finished because I wanted you to sort of talk about your work, outside of the walls of medicine. But before I do that, I mean, I will say a couple things. One is, absolutely, our measurements, somebody who's been doing work, I have an NIH grant doing this and on building medical trust. I would say the measures for trust are still very paltry, right? They do not capture the holistic piece. So Barbara, the work that you all do is critical and seminal and pioneering, like I said, right? Because I think the Wake Forest scale it's reproducible and we know that it captures a lot, right? But Lisa, also what you're talking about is what I as a primary care physician feel when I am in the room, right? I know when I have someone's trust and I know when I'm still building it. And man, do I know when I'm right on the edge of losing it because it can happen so quickly, right? Even when you've worked so hard to build trust. So there are definitely more holistic models that we need to measure. And I think, the fact that there's so little conversation about medication, quote unquote, adherence or therapy plan adherence being connected directly to how much trust you have is also, I think, a real lost opportunity that we need to capture. And that is why I would offer that trust is a social determinant of health, right? It has just as much impact on as whether or not somebody has enough food or transportation or, and sometimes a lot more. So I would now just, kind of going back to you and the work you do in your Dr. Lisa outfit, and just so if people don't know, Lisa has this incredible, I said in the introduction, part of Grapevine Health is actually being out in the community, having these conversations. And I would love if you could share with folks, what inspired that and what things have you learned about building kind of trust in health information through that work?
Thank you for that softball question, Catherine.
Anytime.
Well, Grapevine Health is born from Dr. Lisa on the Street, which is a video series I created many years ago after watching Jay Leno jaywalking. And the reason I put those two things together is because a year or two before that, I was on a panel, and at the end of the panel, a middle-aged gentleman came up to me and he said, "How does someone like me access someone like you on a regular basis?" And he had a doctor, he was taking medications, but he didn't trust his doctor and he didn't trust that he needed to be on the medicines.
Yeah.
Primarily because he didn't understand understand why he needed to take them. And that's why I created Dr. Lisa on the Street, knowing that there are probably millions of people like him who wanted a trusted, relatable messenger who's not using medical and research lingo to explain everyday concepts in medicine. And Dr. Lisa on the Street blossomed into Grapevine Health after I was at Medicaid. I was a medical director at Medicaid for 3.5 years here in DC. And after talking to so many of our beneficiaries or enrollees, I realized a lot of the money we're spending on non-emergency visits, repeat hospitalizations, all the things we care about when it comes to cost savings, they were either linked to low health literacy or distrust. They didn't understand the importance of why they needed to engage in prevention, why they needed to take medications, and just in general, they didn't really trust the healthcare system. And one of the most common things I hear on the street is that doctors are drug dealers. Now, this is very hard to hear, but if you are a non-medical person who's just out in the community and maybe you watch the evening news, most of the commercials are for pharmaceuticals. So they believe we are more interested in prescribing medicines than helping them on their health or wellness journey. So I hear this over and over again. But specific to trust, what has really struck me and has humbled me is the number of people who come up who don't know me or even any of our doctors. There are 5 or 6 of us who go on the street and make video content, but they're asking for a second opinion. Why are they asking a stranger for a second opinion? Because there's a trust issue there. Mm-hmm. And I'll briefly tell this story. Some of you, I'm pretty sure, have heard before. I know Jess has heard it. We were out on the street, and this woman came up to me, and she gave me a banana that she just bought, and she said, "I bought this banana for you." And I was so touched because she gave me this banana that was the perfect banana for me. And I put it in my pocket, and she said, "I want you to eat it right now." And I said, "Well, I'm busy, but I'll eat it later." And she said, "No, I want to watch you eat it." So I said, "Well, tell me why it's so important to you that I eat this banana, and I'll take a bite." And she said, "I want to see if you trust us." And that moment, it humbled me so much because we were out in the community building trust. But her version of trust was, do you see me as an equal? Are you going to treat me with dignity and respect, even though I'm not a doctor? I'm just, a woman here standing on the street corner. And so I think we need humility when we talk about this. We believe we have a lot of the answers, but we really don't. We have to listen more and be humble because they are judging us from the moment they encounter us. And they decide pretty quickly if they want to trust us or not.
Yeah, Lisa, we heard that from patients' time. Go ahead, Asher.
I would just add that when you lose it, it is so hard to get it back again.
Yeah.
If ever.
You don't often get a second chance.
Yeah. We heard from patients time and time again that part of the distrust is the assumptions that are made about them that aren't true. And, the lack of curiosity. I mean, you brought that up. A patient came in for care and he had a family history of taking blood pressure medicine, but having bad reactions to it. And so, he was told this is not a good thing for you. So the first thing the doctor did is said, okay, you need, how old are you? You need to be on this medication. Like, didn't ask him a single question, just made an assumption. Okay, here's somebody, they walk in, this is what they need. And this idea of shared decision-making came up a lot with patients and saying, we are really experts and you have to respect that. If you want me to respect you, you need to respect me because trust is a two-way street. And that's really important. And so, and another sort of symbolic thing was, take off the white coat, which I know has rubbed some people wrong. But the idea is, like we're both people here. Let's have a conversation. Let's talk to each other and share our mutual or respective expertise so that we can come to a plan.
Medicine is a very paternalistic industry. We have a lot of orders for the people we help, patients. Sit here, show up here, go there, do this, do that. We want them to be on time, but then we make them wait. It's a good example. So they're paying attention to all these things. And I think we just have to be more mindful. And I'm painfully aware of all the challenges of healthcare delivery, having worked in health systems and run a clinic. So I think we just have to be more mindful about how you do this, even given the time constraints, because sometimes it's just the body language that communicates so much. Like a woman who told me she knows when she needs to stop talking because her doctor moves toward the door and then puts her hand on the doorknob. So,
It's
just a subtle
interesting.
thing like that lets someone know, okay, she's not really interested in listening to me.
I was a patient experience coach, which meant going into the clinic rooms with a number of different physicians just to give them feedback, and how often the doctor just didn't even sit down.
Yeah.
And it's amazing. There's actually data showing that just the act of sitting down, the perception of the patient is that the visit is longer.
Yep. Interesting.
Yeah, Asher, I would love to kind of play that out a little bit more in terms of, other pieces that you have noticed, because like Lisa said, there's so many constraints in the way the healthcare system is delivered. And I'm sure a lot of people here are saying, okay, well, that's all well and good, but I only have 15, 20 minutes with somebody. In thinking about your work as an educator, what are pieces that you specifically, besides the sitting down, where are other things that you've specifically tried to underscore for your learners, and folks who are training in to be a healthcare professional?
I was always teaching them to ask them, what's on your mind today? What are your concerns? And one of the things is to recognize that often the first or second concern isn't their major concern. It may actually be the third or fourth one down. They're just a little reluctant to put it up there. So I get it all out, try to have them get it all out there. And then I do teach about negotiating, what is the most important for you today?
Hmm.
Did you want to make this? We may not have time to get to everything, but I want to make sure to address what is most concerning to you today. And it may not be their diabetes or their blood pressure.
Yeah,
And that's okay
yeah.
because that'll be likely that they're more likely to come back the next appointment and then you can address them. But if you don't address what else is going on that they're really worried about, they're not going to come back.
Yeah, I will say, I totally agree with that. One of the things, I have medical students and residents with me all the time. And the thing that Lisa, you do in your work that I think a lot about is really being very clear with people who are in training and all of us that, look, you're learning a language when you're learning medical jargon, but your job is actually to unlearn that language and or be a better translator, right? So the more plain talk you can do, the better doctor you are, right? And so like that, and so I have them do all the presentations in front of the patient. The patient is their teacher, right? The other thing is really I teach and also kind of offer as a perspective that when I meet somebody and they're establishing care, I make it really clear that they are the expert on their own body, right? Because like, this whole idea that I somehow know their body better than, them when they've lived in it for 50, 60 years is completely ridiculous. So you're the expert, you're in the driver's seat. I'm just in the passenger seat, here to kind of help with some tools. So I think that can go a long way. And then the other thing, which is an art and not I get humbled by it every day, is checking your own biases, checking, like, be humble enough to check what's going on for you. And I shared with the three of you in last week in our practice session or just our connection before this is, I shared I have a patient. I've been honored to be a family medicine doctor for over 20 years. I have some patients who I've seen continuously for that time. I have one patient who came in always very difficult to access, always wearing sunglasses. Oh, I had no idea, always sort of laughing when I offered kind of some medical knowledge or insight or input. And I kept thinking, well, I'm going to keep showing up. And he kept showing up. And we developed this relationship over time. And this last time I saw him, he wept to me and he said, "You and my mother are the only people who've ever been here for me." And I watched my daughter get shot and killed 15 years ago. And it was right around the time I had started taking care of him. So it was like he wasn't able to go there, but I had to check myself at the door every time he was on my schedule because I was like, where is this going? How does he keep showing up? And what am I any good at my job? Right? Sort of thing. That feeling. And it just took a long time. So I think that's part of the beauty of our job in primary care in terms of getting to have that continuity and some of the healing that comes out of that. Um, I wanted to ask a question to each of you, and you can sort of answer. It's a little bit left field, maybe, but I think it's critical for us to be talking about, which is around AI. So, I think a lot of us are thinking about. Obviously, if you're not talking about AI in medicine, you're not. It's like an important conversation right now. So, thinking about where it could be a facilitator and where it's a barrier for building trust. And what are your perspectives and anything that you want to offer on that? I know it's an emerging field. We'd love to hear some perspectives.
Well, I can start. MHQP's been doing a deep dive with all of our stakeholders about how do you implement AI that's equitable and patient-centered. And that's a big challenge. And I saw a headline recently in a journal, I think it was a stat, and it said AI should be moving at the speed of trust, not at the speed of profit or whatever it's, the business. And I thought that was so important. But of course, this is America. We're a capitalist society. So things like this move so fast and it gets so far ahead of people. There's interesting polls that show, people distrust the concept of AI, but if it helps them, they trust it. And so, it's like, so that, it's a little conflicting. I think there's so many ways to unpack this. And if AI can help, as it seems to, with ambient note taking, help support the primary care clinician. Patients care about that. They care about their doctors. And so so they say, okay, well, if this is helping you, I'm okay. And, some people think beyond like, well, where are these notes going and how long are they kept and, what's in them? I mean, there's obviously some really red flags that we are, as a system really need to address, that I don't think have been addressed to the point we need them. But there are, certainly some benefits. And one of the things that I think is really difficult, and causes distrust is lack of follow-up. When you're given orders and then nobody follows up and nobody gives you a call and say, well, did you do this? And so if there's some specific solutions that AI can address that we know are challenges, then I think that would be a good thing because our system is so fragmented and, convoluted and it's so difficult to navigate. So if you pick some particular friction points and say, okay, let's use AI to address this in a way that's, transparent. I think that, you have to hope that that's going to help because we need the help. Our system is in such a state that we really need we need improvements. So that's it's a double-edged sword, but I think if it's really focused and transparent, I think it can be a positive thing.
Thank you. Before either of you answer, I just wanted to say we're not yet taking questions, but I do see that one of the questions in the chat is around AI, chatbots, and good products to help build trust. So
Mm.
we are thinking about that as we, and also this is harvesting wisdom from the 150 plus people who are here. So if people who are here are like, I have the perfect AI chatbot to bridge some of these things, please put it in the chat as well. Okay, so Lisa and Asher, any thoughts on AI and where this plays a role in trust?
Lisa, go ahead.
I have lots of thoughts on this. In addition to Barbara's comments, which I agree with, it's a great helper, and I'm so glad it's come along for a lot of reasons. We've been asking people about this issue, what they know about AI, do they use it, how do they use it? And it turns out probably over 50% of the people we've asked about this, they don't actually know they're using AI. And the most poignant example is from a trip to Alabama. And I posted about this on LinkedIn some time ago. I asked a woman what she thought about AI, and she said, I think it's all fake. Everything is just fake, fake, fake. And when we got into it, she meant videos because she didn't realize there was another utility for AI other than deep fake videos.
Mm.
So I said, I see you have a cell phone there. What do you do with your cell phone? She said, all sorts of things. I talk to Siri, and sometimes when I send a text message, I just like talking to my phone. I said, all that is AI. And she was shocked. And she's not alone. I think we have to make sure that as we are building all of these tools to support people, number one, they need to know about them. And number two, they need to know how to leverage them as well, because I think AI can be a great tool for people pre-visit, post-visit. The reason I started my company is because we are doing a lousy job speaking to people in plain language about their diagnoses. So many people will text me personally, give me the login to their mic chart and say, please look at this and tell me what it says. What does this mean? And I think a lot of the large language models are really useful for that, but people don't always know they can use that. And I had a woman tell me just last week, I think it's great when I have a question. I use chatbots all the time, but I don't want it to be my doctor. And the last thing I'll say here, and it loops back to the previous conversation. We haven't talked about the loss of touch in clinical care. And this is severely eroding trust, whether we like it or not. So these conversations about whether or not AI will replace doctors, hear me now, believe me later. It never will, because this will become more and more apparent to us. Not only the dangers for patients, but the liability that will ensue when we are not touching people and doing complete physical exams to really understand what's happening. But this is the easiest way we have as a clinician to build trust with people, is to touch them. So I love AI, but I think there are some dangers, and if we're not careful, um, it'll get too far ahead of us, and we'll be too far behind to catch up.
There's so many pieces that you said that I wanted to underscore, but one piece in particular, what you were just talking about in terms of the importance of human touch, right? So I would just say using AI as a family medicine physician now and being able to use it to help, obviously after permission is granted with all the notes, I have brought touch much more back into my practice because I no longer need to be tied and shackled to the computer, right? So I can actually have my phone, in their chart recording the conversation, capturing what they're saying, but while they're talking about their knee that's hurting or their headache, I can be actually evaluating them clinically and having them up on the clinical exam table and all of that. So that's I think, a perfect example of how AI can be used as a bridge to build trust. to that point. And then the second thing I wanted to say very briefly, and then Asher, I want to hear your thoughts, is around transparency, and what you were saying, and people getting the results in my chart and not being able to know what to do with it. One of our questions is really like, how can people trust a medical system that is not transparent, right? So how can we have true transparency, right? Because just releasing a bunch of labs to people is not transparency. And so I like what you said about it, right? Like, how do you
Yes.
actually ask the right questions and figure out what it means, without being scary?
We've tried to explore an intervention to address this, but we can't figure out who really cares about it enough. I
Mm,
mean, I think patients care about it, obviously, because their labs are confusing to them no matter what the report says. But outside of that, I'm not sure. And I would love to hear from the audience. Like, who cares enough about this to really implement interventions? And I'll just say one more thing before turning it to Asher, and that is, someone in my life was recently diagnosed with breast cancer. And
mhm,
it turns out they caught it early, but it turns out when they look back using AI at the previous films, it was there. And I think, again, physicians in particular do not like liability, nor do the compliance officers and, the legal officials at our health systems. We need to be giving serious consideration to how we're using AI and how it can help us in diagnosis and mitigating liability, whether we want to talk about that or not. But this is
mm,
a really important utility, I think, for AI in healthcare.
So
thank
one
you.
additional comment I would make with relation to AI is there's an opportunity to actually collaborate with patients in using it. And so when they come up with, here's what I found, it's an opportunity to let's go look together and let's see what we're able to come up with. Here's an opportunity now to actually show people the right way to questions that might be more effective or how they might get more effectively get the answers. And then it just allows the patient to feel more comfortable that they're using it. They know their doctor's using it and not to feel embarrassed to let the doctor know that I'm actually using this, and that's okay. I really would appreciate it if you share with me what you're finding, because sometimes you can get mixed messages. So I think there's an opportunity there. And then just a comment about touch. It's really funny how touch has become less sort of allowed. And I'll have residents say, well, there's no evidence to support that doing this part of the exam is actually helpful. And I say, well, actually, touching patients is always helpful.
Oh,
And
wow,
that
that's
there's
very
such a way of
disturbing to
connecting
me.
with people when you can just touching them. It's one of the reasons I went into medicine, not psychiatry, is I wanted to touch patients. And I think that that's really huge.
So, we could really be talking all day. We did kind of allot some specific time to answer your questions. So if you haven't put them in, and also if you are listening and you're like, yes, Lisa, I want to make sure we have something around transparency and medical results and all of that, and I care about that, make sure we're responding to each other too. I actually am going to pull up a question that's really around, the elephant in the room, which is social media, and thoughts about sort of like how does one address the misinformation and barriers that we know exist around the misinformation in social media. Because we know that that is an accelerant for mistrust a lot of times. So I'm going to just put that out there and let anybody jump in who wants to start.
Well, I'll just start because our clinician council has talked about this at MHQP and particularly the pediatricians around vaccinations. And they're just talking about the amount of time and energy it takes. And I remember years ago around, sort of trying to talk a patient saying, no, you don't need antibiotics. It's really not, it's not going to help you. And they'd say, I do a really good job until 11 o'clock. And after that, my schedule's a mess. I'm exhausted, and I just don't have the resilience after that. So I think it puts a tremendous amount of pressure on the clinicians to have to sort of negotiate these things, and the idea that every patient, it's a personal choice as opposed to, no, this is the evidence. This is what the evidence says, and it's not just the individual, it's the public health. So my heart goes out to all the clinicians working on this right now, and hope we can get through this phase where everything's
I
gets
don't
back
think
to
it's
evidence.
I don't think it's a phase though. It's always been here. It's amplified now, post-pandemic, during and post-pandemic, but also because everybody has a phone and people have access to social media. When I became an infectious disease doc back in the 90s, I would do town hall meetings at churches and community centers, and people would often bring up misinformation, particularly about HIV, where it came from, why it's here, why the pharmaceutical industry is making so much money. This misinformation has been on the grapevine about lots of different things for a long time. And I have been humbled by this as well, because I used to have an attitude that was rather indignant. How could you possibly believe that? That's absurd. And now I approach this with curiosity, and I want to understand, where is that coming from? Why do you believe that? And helping people understand the how and the why of something is something we are woefully inadequate. We like to tell people that's what this is. Here are the data, show people slides and graphs that are really compelling to people, like me. I'm an epidemiologist. I love data, but people don't want to hear data. They want to hear stories. And they heard about what happened to their neighbor when they got the vaccine, and whether it was related or not, that's their reality. And so I try to understand that and help them deconstruct it. And sometimes you win and sometimes you don't. But I think trying to listen to people and really understand where it's coming from has been pretty helpful to me in trying to address the misinformation. But I agree that it takes an overwhelming amount of time. I mean, that could be my full-time job to address, misinformation on social media. But I think it's all hands on deck. It's kind of warfare right now. So we need to be out there trying to dispel this information in the communities where we're trusted, because we're all trusted in different communities.
Yeah.
Well, it also means cultivating the relationships. And I think that's really what's key. Most people actually do still trust their doctor. And even if it's a long conversation, it's a conversation to revisit, if they have a relationship that they trust you, they're more likely to listen to what you have to say, and maybe eventually they'll begin to appreciate where you're coming from.
Yeah, I mean, I think that taking the time, asking the questions, asking open-ended questions, again, it's like checking your own bias at the door. It's like, why does that bother me that they have that, like information? And rather just
Yeah.
being like, what do you understand? Like, help me understand more about it, or what are you afraid of? And I think asking those questions in particular for me around vaccines has become really important. And also meeting people where they're at, not saying it's like my way or the highway, but allowing people to obviously continue to make their choices, and sharing where you can in terms of like, whatever information might be most helpful. So I think this is a really important question that we could kind of ponder on more.
Catherine, can I just
Yeah.
say one other thing about this? I think a lot of misinformation is rooted in a kernel of truth that by the time it gets on the grapevine and people are confused, it gets so wildly distorted, it looks like misinformation or disinformation. And I've had lots of examples of this, people asking questions, and I wonder, well, where did you get that? And once you hear why they believe that, it's just because the information is like the game of telephone. By the time it passes through two or three iterations, it's completely distorted.
Yeah. Yeah.
I think
I
it's
think that's
important to appreciate as well that these are not one and done conversations. These are
Yeah.
often conversations held over many, many visits. And you just have to be patient and not judgmental. You have to just check judgment out the door. And take it as it comes.
Yeah.
And you need the continuity so you're seeing the person again.
Well, that's an important part too. And one thing I didn't get to bring up is how challenging continuity is now. Just seeing your own patients can be such a challenge. I don't know how it is for you, Catherine, but I always had difficulty being able to see the same patients, and that made it really hard to make those relationships really robust.
I think that that's really a choice that practices need to be making and prioritizing. So we now have dashboards around, continuity, and we score how things are being done and how often a primary care provider has continuity with their own patients and how often their patients have continuity with them. And if you have high continuity, like if I'm seeing, and now, we're really looking at this data a lot because we know continuity builds trust and we know trust builds positive outcomes. If as a provider you have high continuity with your patients, but not all your patients have high continuity with you, it means you have too many people on your panel, right? So there's I think really thinking carefully around relationship as that, and I'm bringing it. Want to go back to one of the questions in the chat, which is really thinking about this two-tiered system that we've created and we're perpetuating where some people buy, more time with their provider and can have a kind of more time for all these dialogues we're talking about are so important. And some people are not in a system that pro offers that. We've talked a little bit about the challenge of time, but I wonder if there are other kind of things that you all as panelists would offer as like how do you actually bring down the inequities in this two-tier system, which is for now, unfortunately, part of the road we're on.
Well, we're people creating these systems, so we can make a different choice.
True, true. Yes, all the policymakers in the room, please, yeah, take
Not
note.
not not only
Not just
not only
policy.
them. I mean, as
Yeah,
a physician entrepreneur, I hear often physicians don't make good entrepreneurs because we're not open-minded, we don't listen. And I think part of that comes from just throwing yourself in different situations, raising your hand to volunteer to be on a committee, interact with people in the C-suite who are making decisions and making sure they understand the impact of the decisions they make. So there are different ways, I think, to influence this. It's not just the policymakers, because the policymakers need the information we have
that's
to
right.
make good policy.
That's right. That's right. A real call to action of having people here who have this frontline experience to be sitting at the table. Okay, so any last word? It's now 2:58 and we are careening around the corner to 3 and we want to make sure we end on time. Any concluding thoughts, Barbara and Asher?
I would just say, if you have a really good trusting relationship with your clinician, I think it's a lot more, it gives you feel a lot better about your work. And so that's something it takes time, but I hear, I'm not a clinician, but I hear it can be incredibly rewarding.
That's
I hear
awesome.
this from you, Catherine, actually.
I was like, that's so true. And I was like, oh yeah, I said it. But it's a perfect antidote, I think, to some of the brokenness of the system is that relationship.
I
Thank
think it
you.
correlates to decrease in burnout.
Yes. Yeah.
One of the things I've learned on the street, Catherine, is that not everybody wants a doctor.
Hmm.
And we have to be okay with that. And maybe we show up in non-clinical ways to show that we are trustworthy, listen to people, and then maybe they will want a doctor.
Yeah.
But it takes a certain level of humility to recognize that primary care is not for everyone, at least not right now, maybe later.
Yeah. Wow. Well, we definitely could go on for the rest of the day. I just want to extend a huge thank you to you all. You're such remarkable leaders and panelists, and really, I loved exploring sort of the complexity and urgency of rebuilding trust in primary care. I also really want to thank PCC and ABIM. And want to remind everybody that this webinar was recorded, so you can listen to it again and again. And we will be posting it on the PCC's website, which is thepcc.org, within 48 hours. And it's now 3 p.m. and really grateful for our time together.